So thank you. So I want to talk about the concept of quality of life and what matters to people living with HIV now in the era of ART and in a global context. And in summary, what I would like to cover in the next half an hour is, first of all, what do we know that matters to people from global primary studies? First of all, in qualitative studies, i.e. what are people telling us matters to them? And also in quantitative studies, what are we measuring? And the important thing to remember here is these two things aren't necessarily the same. We don't always measure what people tell us matters to them. I'd like to reflect on the evidence of what the risks are of us ignoring patient-reported problems and person-centred care, and then move towards a kind of a model and some ideas of how the care that we deliver can be more person-centred, underpinned by the importance of outcome measurement and some of the developments we've achieved in that. And then, importantly, what can we do that really makes a difference, and some findings from a couple of clinical randomised trials that we've been running. Excuse me. So first of all, qualitative and open-ended data, very important. What do people tell us actually matters to them? So first of all, a study of about 350 gay men living with HIV in the UK. We asked them at the end of an online survey, what matters to you? First theme was, I need better clinical care and I need better medications. I need more understanding from the HIV doctors about side effects and mental illness, which really tells us that assessment doesn't always address what matters to the person in that clinical encounter. I need improved clinical services. I need better mental health. I need better general health, things like low energy, depression, and the ability to establish a positive outlook. Because we do, of course, hang everything on the reduced morbidity and mortality related to ART, but we need to make it a life worth living. And people need personal skills. I need to rebuild my confidence and my self-esteem. I need to find a way to move forward in every area of my life. And this is a study we've just closed in the UK. It's a UK-wide study of LGB and/or T people across the UK who have advanced illness. Here's an interview we conducted this year with Tom, who's a gay man with HIV and COPD. And he really talks about how he doesn't necessarily fit the image of a service for somebody with COPD. I felt very, very excluded. They don't get patients like me. So when I've had pulmonary rehab, it's me and a class of 80-year-old women. I can't be the only 44-year-old out there with bad lungs. Her breathlessness, it leads to mobility issues, it leads to social isolation and hiding away from everyone. So we can immediately see how we need to be multidimensional and person-centred in the approach we take. And because of my various conditions, I have to juggle 7 or 8 healthcare providers. I have no idea, and again, I'm sure this is a story you hear routinely in clinical practice, the complexity, if you've got a multidimensional problem, of having to deal with multidimensional staff. And here's a 64-year-old gay man living with HIV and advanced prostate cancer, not knowing what's out there. How do I know what question to ask? That's the difficulty. Nobody's bothered to sit down and really talk to me about what's going on. I've had to sort of muddle my way through. This is incredibly complex for somebody. How do they know what the clinician needs to know? If we don't have structured, holistic, valid assessment tools that identify all the areas of need, we're never going to be able to coordinate good person-centred care. Here's another man with HIV and COPD, and here's a classic example of people on a conveyor belt in and out of A&E. I invariably go into A&E and Hospital X. We're on first name terms and they clerk me in easily. I've had excellent care. But if I go to Hospital Y, it's not a nice place to end up. They don't have a backstory there. It's hard to go through 20 or 30 years of history when you're breathless. The other main symptom I've had is falls. I have Cushing's syndrome from the steroids and terrible pain and leg weakness. I get stuck in the bath. And that's what put me at the suicide risk in the first place, severe worrying. So we can see how everything goes from a physical to a social to a psychological problem. In this man's care, it needs real coordination. Moving away from Europe, I'd like to move over to sub-Saharan Africa, where we led a big public health evaluation for the US government, and we interviewed 83 patients, some caregivers and some staff in 12 sites in East Africa. And here's a person accessing outpatient care with ART availability. My chest is painful and uncomfortable. I have painful joints, especially when I'm sleeping. When I lie down, it becomes difficult to rise up. So these are people living in the community with very, very few resources, which provides an enormous need to provide support to informal caregivers in rural settings particularly. My whole body hurts and I spend a lot of time in bed. I have no energy and I'm not able to get out of bed. Now you imagine that in the context of a subsistence economy, where if you don't get out of bed, you don't go and grow vegetables, you don't get to the market, your family has no food and no income. The implications of this are really stark. And this caregiver saying she has severe pain in her right leg and sometimes she applies medicines and it stops, but it's recurrent. She's experiencing the pain and she's not able to walk up here with me. That's why I have to go and collect her drugs from the clinic. So you think of the family implications of that. You've got the patient in bed, not economically productive, the family member having to go to clinic to get drugs, they're not economically productive. So there's huge implications of this. The ARVs at times cause me stomach pains and pains in the leg, severe headache, rotational dizziness, and I feel like I lose balance and focus. Again, this person is not going to be able to be economically productive. It's okay for us where we have a welfare state and you're going to have some basic provision of income and welfare, but for this person that doesn't exist. She's been falling down sick time and again with malaria, fever, diarrhoea, general body pain, limiting her from doing any work. Again, a person that can't get out and generate an income. So that's what people are telling us. So what are we measuring? Let's look first at some EuroQual data from a sample of around 800 people, outpatients living with HIV back in London. As you know, the EuroQual has 5 dimensions, and we use the 3-level response here, which is slightly less sensitive, and the visual analog scale of 0 to 100, ranking your self-rated health. Now, as we presume that people are doing well on ARTs, there's this nice kind of idea that ARTs are a panacea. We can see here that around a third of people in London in centres of excellence are reporting some problems with mobility. Around 20% are reporting some problems with self-care. Around a third are reporting some problems with performing their usual daily activities. Pain and discomfort, pain and symptoms, big interest of mine. We've got around 43% of people having some pain and discomfort, and as you would suspect, a very, very high prevalence of anxiety and depression. Around 58% of people presenting with mental health problems. And when we look at that visual analog scale, 0 being your worst rated general health today, 100 being the best, we've got around a quarter of people scoring themselves in the bottom half of that scale. So people really do have self-perceived quality of life issues. And in terms of what's correlated, so we ran a regression model to look what was correlated in terms of the dimensions within the EuroQual, but also clinical and socio-demographic variables, to see what's correlated with how they score their general health on a scale of 0 to 100. And we can see that the mobility, the usual activities, the pain and discomfort, and the anxiety and depression are well correlated with the and contributing to the self-rating of general health. Also, treatment optimism. If you're more optimistic about treatment, you report your general health better. Having a sexual partner was also protective for rating your general health. But very interestingly, none of these variables were, in the multivariate regression, none of these variables were associated with self-rating, including ART use, CD4 count, and viral load. Very interesting. And within this model, we managed to explain 45% of variance, which is not bad. What about the burden of symptoms for people living with HIV? Here is a study again from our cohort of nearly 800 people in treatment centres of excellence in London. The most prevalent, look at the last 7 days using the MSAS short form symptom assessment scale. We've got over 70% having a 7-day period prevalence of lack of energy, drowsy, feeling sleepy, difficulty concentrating, diarrhoea, sexual activity, pain. All of these have got over 50% 7-day period prevalence. And again, you imagine the burden of living with that, living with diarrhoea, living with pain that's enduring and chronic. A real challenge for these people. And if we look at how much they score, look at the proportion of people who are scoring the worst end of the scale for these problems. This is not a minor problem for many people. And when we look at the psychological dimensions of the MSAS, we can see a really high prevalence of feeling worried, sad, and feeling irritable. And you may also want to look, we did a systematic review last year of all the evidence of psychological problems, prevalence of psychological problems of people on ART globally, published it in the International Journal of Nursing Research. And the global prevalence of anxiety and depression is between 35 and 45% for people on ART. So again, ART is not a panacea. And I don't want to labour the point, but we've been conducting these HIV symptom research studies around the world in London, Argentina, Kenya, Uganda, a multi-site study in South Africa and Uganda, big study in Soweto, and we've just got some data in from almost 1,200 patients in Vietnam, finding a similar story of a high burden of pain and symptoms for people living with HIV. But what are the implications of this? Do we need to address pain and symptoms? Well, from the personal perspective, of course it matters. Living with that enduring burden is an enormous problem. But if we take a more kind of clinical and public health argument, we've published data showing that pain and symptom burden is associated with unprotected sex, it's associated with poor adherence, it's associated with viral rebound at 12 months, it's associated with poorer quality of life, it's associated with suicidal ideation. We found a third of people in our London clinic had considered suicide in the previous 7 days, and it's also associated with ART discontinuation and change, which is not so much of a problem where we have additional lines in high-income countries, but in low-income countries that would be a real problem. Interestingly, stigma is important, and I'd just like to mention this study that I found that showed that older gay men, perceived stigma, accounts for 39% of variance in their quality of life. So stigma is a real problem for quality of life. And what do we do what do we do in terms of improving subjective well-being? I thought this study was quite interesting. A nice little study that showed that meditation and prayer could improve subjective well-being. There are things that we can do. The whole argument about ART and quality of life is a complex one. The data is quite confusing. There are some studies that show that it doesn't, and I've got some data that shows that it does, but it's not always a clear picture. But quality of life, I think we can agree, is a critical challenge now to HIV medicine. And there have been few intervention studies that have really tried to test models of person-centred care, and I'll come back to that. So what do we find in our big PEPFAR study? We've got a cohort of around 1,400 people in 12 sites in Kenya and Uganda. You may be aware of the policy of 90 by 90 by 90, so by the year 2020, 90% of people should be tested. Of the people that are positive, 90% should be on ART and 90% should achieve undetectable viral load. By 2020 in Africa alone, that's 15 million people we're looking at. That's an enormous amount of care we need to provide. So we looked at this cohort of people living with HIV in East Africa. There's a range of people on that had CD4 available, and I just want to mention, actually, while we're trying to roll out treatment, we published some data showing that around half of people in Kenya did not have a recent CD4 count on record. So it's quite difficult sometimes to implement that policy, particularly when it's around CD4 counts for initiation of therapy. What were people's worst problems? They were psychosocial. Their worst problems, scoring the most severe end of the person-centred outcome scale on worry, sharing feelings, and help and advice to plan for the future. So big demand for those 15 million people who need better care. This data came out in BMC Infectious Diseases in 2014, and I've just focused on the functional status covariates for this audience. When we looked at the MOS-HIV quality of life measure of the person-centred outcome scale, when we did a multivariable analysis, we found the mental health subscale was lower for people with limited functional status. Physical health scale of the MOS-HIV was lower with limited functional status. And on the person-centred outcome scale, it was more burdensome. Multidimensional problems were more burdensome for people with limited functional status. This data we've just analysed in the last few weeks, looking at newly diagnosed people in East Africa, 438, followed them for 4 months monthly from the point of diagnosis, within 2 weeks of diagnosis. Around a half initiated ART during the study period, and when we adjusted for their demographic and clinical variables, we found there was improvement over time for the MOS-HIV physical health domain. So we can find some improvement for the physical aspects of quality of life over time. But again, I've looked at the physical health variable for this audience today. Limited physical function at baseline, so when you turn up in the first test, if you have limited physical function, it's associated over time with worsening physical health scale, worsening mental health scale, worsening physical, psychological subscale of the patient-centred outcome scale, and worsening existential problems as well. ART did improve mental health, but not physical health over time. So what do we do with all of this? I mean, as Diane Meyer in New York always says, we have to stop admiring the problem, we have to do something about it. So what do we do in intervention studies? Well, the first thing to do, we need to think about better models of care. Let's think about what we mean by health. I mean, I always go back to the WHO when it was initiated, 1948. What did they say health is? It's the state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. For me, this is the goal. And health-related quality of life is important. It's an assessment of how well the individual's well-being may be affected over time by a disease, disability or disorder. And for me, and this is a quote from a friend of mine at the Institute for Human Virology at the University of Maryland. She always talks about going from the life of the virus to the life of the host. So we need person-centred care that encompasses spiritual problems, emotional problems, social problems and physical problems, and takes a holistic approach. And can we do that? Well, we've had a long-standing programme in sub-Saharan Africa to develop and implement outcome measures. So first of all, systematically reviewing what was available, reviewing the Lancet in 2005, I think. Then asking HIV care providers across Africa, what do you need? What do you need? Outcome measures, we have the green light to do the work. Then doing consultation with multidisciplinary professionals across Africa to develop a tool. And then developing it, and then validating it among about 800 patients at 5 centres. It's a very brief scale, it's got 10 items, we take as little as 3 minutes to complete over time. We've translated it into Afrikaans, Sutis, Kiswahili, Xhosa, this is Zulu, Gauteng, Natal, Uganda, Rwanda, Europe, Kenya, Swahili, Tanzania, Swahili, Luo. And very interestingly, you have a colleague from the University of Lancaster who's been doing his PhD translating it in Mauritania, where they have an oral language tradition. So how do you translate a written scale when you only have an oral language tradition? So that's been an enormous challenge. And interestingly, we have a lovely example of South to North learning, the measurement of ACPs, which was developed in African HIV cancer care as a measure of spiritual well-being, has been imported into the UK. Patients and families told us they like it. And now the UK government has it as a standard measure rolled out within our National Health Service. So a lovely example of what we learnt in Africa now being the tool in the UK. And does this actually work? Do we embed it into practice? Well, actually, yes, we have. It's been embedded into routine practice across sub-Saharan Africa, helping audit and training and management resources, allocation and research. CIPO is a big US government-funded study. They put $25 million into improving community-based care, and they're using the variants, HIV variants by scale. In Africa, we developed the world's first ever prompt for children that was progressive and advanced conditions, and now we're trying to take that science that we developed in Africa and get it funded in the UK. And we've also looked at different ways of scoring. How do you help somebody who may not have good language skills to score? We looked at different hand scales to help people use patient-reported outcome measures, which we've also validated. An important thing to note, HIV services in sub-Saharan Africa really have taken that integrated care model, so you can be referred to palliative care from the point of diagnosis. Just to ensure that while you're on ART and you're ostensibly doing well, that you get person-centred care. It's not necessarily about advanced care. And the really exciting thing is the person-centred measures that we've developed are now in standard documents in sub-Saharan Africa as kind of guidance on what you should do. And if you want to be a 5-star accredited palliative care provider in HIV, you have to use the outcome measure. So we have a number of documents now which state the measure has to be a standard of care. You have to measure patient-reported outcomes. And what do people tell us? There were 72 delegates at a meeting from 16 countries in Africa who wrote this paper independently of us and said, measuring the quality of care provided was problematic without rigorously validated outcome measures suitable for use within a resource-constrained and culturally different African context. It was a locally led project. So finally, what can we do in terms of intervention studies? Well, this was published at the end of last year. We took all that data from the US government evaluation we ran, showing what people's most important person-centred problems were, that big cohort study. We developed a randomised control trial on the back of that, which we ran 2 separate trials in Kenya and South Africa. This is the Kenyan data. simple 2-week training course, training and mentorship for existing ART nurses in a really, really poor township just outside Cape Town to help them to do better holistic assessment and care planning. So from this trial, we found that, yes, indeed, after 4 months, the people in the intervention arm had better mental health on the MOS HIV subscale, they had better psychiatric morbidity on the GHQ-12, and they had better palliative care problems on the person-centred scale, particularly psychosocial items on the POS. Our outcome of pain was not affected, but all the other psychosocial outcomes were. And we talk about integrated care as well. The care should be integrated. I showed you that guy at the beginning, had so many people giving him care, he didn't know what was happening. So can we really integrate care? So here's an RCT that we published year before last in Lancet Respiratory Medicine, where we set up the breathlessness intervention service. So anybody with an incurable condition who was reporting refractory breathlessness, they could get a single point of care which integrated palliative care, respiratory medicine, physiotherapy and occupational therapy. And in the intervention group, mastery was improved compared with the control, but also, really importantly, survival was better as well. Many of these people were advanced patients with lung cancer and COPD. We had better survival, which also echoes, you probably saw the big TEML study, the big RCT of early intervention of person-centred care for advanced non-small cell lung cancer patients in New England Journal of Medicine, who found that early integration of person-centred care also improved survival. So if you're person-centred, you really can improve some major outcomes. This wasn't my trial, by the way, this came from our team in my department. So, what does this all mean? What do we need? Person-centred care is what we need. And how do we achieve that? Well, I believe that we can't really deliver person-centred care without a structured assessment tool that allows the person in front of us to identify what matters most to them right now, and that we monitor that over time. We need person-centred outcome measures or patient-reported outcome measures. Within rehabilitation, goal attainment scaling is an important way to achieve that. We have a joint academic department of palliative care and rehabilitation. Our professor of rehab, Lynn Turner-Stokes, has done a lot of work on goal attainment scaling. Now in the UK, for every episode of specialist rehabilitation, goal attainment scaling data is recorded in the UK ROC, Rehabilitation's Outcome Collaborative. And that's being used to measure patient complexity, outcomes and costs for the Department of Health. And you can read more of that in the BMJ Open recently. Lynn's published a paper on the UK's model of goal attainment scaling. Also, we've been doing this with the MildMay, the Neurocog referral centre for people with HIV in London. All of their data is now going in for the last year and a half. They've been collecting UK ROC data as well. The important question is how we make health-related quality of life and patient-centred outcome measures direct care. We do know from systematic reviews we've published it can make a difference to patient outcomes, but you have to use the data. You don't just do an assessment and put it in the drawer. It needs to inform the care you deliver. And a lot about that is making sure that you involve staff from the outset to make sure that their needs are met as well. Getting the right content validity for your measures. You know, there are many aspects of face validity, content validity, all the kind of test, retest, sensitivity to change, all of that. But if you don't have content validity at the beginning, it doesn't reflect what people with HIV tell you matters to them, then your measure is not going to be appropriate. And I'm working on an EU-funded kind of 7-country study to improve mHealth for about 7,000 people living with HIV across Europe to get onto their apps. We've been looking just in a systematic review of quality of life measures and found some of the big ones like the MOS HIV has very little or no data on content validity. So people living with HIV have not influenced the content of those tools, which is a major concern. And so on the back of that, from that finding, we've just got funding. We had our first meeting in my department this week. I'm leading a project to develop a UK PROM with and for people living with HIV to help them identify what matters in their care with the British HIV Association, so it can become the UK standard that all of our clinical care is led by PROM developed with and for people living with HIV. And that's me. Thank you very much.